Rolling, Gwen, whenever she's ready.
Okay, is that good?
Yep.
Okay. All right, we're going to get started. This is being videotaped for the future, so if you are somewhere you shouldn't be, just duck. No, I'm kidding. So what we're going to do is show a short video today that was produced by the New Jersey New Jersey Hospital Association, and then there'll be a PowerPoint short lecture after that about end-of-life care.
My name is Anna, and I am 86 years old. 86 years of a marvelous full life. I don't know if anyone has told you this before, but there's a strange moment in life when you realize that everything is behind you. You'll be busy with your life, doing what you do every day, and then it will happen. You'll look at an old picture and realize it. There's just not much ahead of you anymore. It won't be a terrible thing. I'm sure your life will be a lot like mine and be more full than empty. My husband gave me a beautiful family and nearly 40 years of a wonderful marriage before I lost him nearly 25 years ago. And it's been nearly 18 years since I lost my daughter suddenly in an automobile accident. I don't think I would have made it through the pain of losing her if it weren't for my angel Christina, my only granddaughter. We have had many wonderful years together. She was the light of my life. Sometimes a challenge, but a good girl. I worried more about our finances than Christina's behavior. Luckily, I had gone back to work as an accountant for a small business after my husband died. I enjoyed many years with them and continued to work part-time all through the years of raising Christina. Christina finished college and got married to a wonderful man. And I now have 3 beautiful great-grandchildren that I love very much. After Christina was raised and married, I finally had time for myself. I traveled with Beth, my childhood friend, and we saw a great many places around the world. Beth is in one of those assisted living places now, and I am in a nursing home ever since my stroke. I can't even get around without a wheelchair and an oxygen bottle. I know I need full-time care. I just don't want to be a burden. I never dwelt on what could happen to me in the future, but I sure didn't expect this. I don't know how it ended up this way.
It was dinner time and all of the residents were here in the dining room eating. Anna was in her usual seat at this table when I noticed that she was not eating and she appeared to be slumped down in the wheelchair. I went over to talk to her and she seemed to be having a hard time breathing. And she couldn't answer my questions. Normally I was very cheerful and talkative at dinner, but she didn't look good at all and her hands were shaking, like she was very upset. I ran to the desk and told her to call the nurse and to call 911. We took Anna away from the table, back to her room to wait for the ambulance. I was very scared for Anna. She looked like she was dying. Anna was one of my favorite patients. I took care of her for 2 years. She was so pleasant, always trying to cheer up the other residents. I hope she's okay.
We responded to the call at Hilltop Nursing Home where we found an 86-year-old female in moderate to severe respiratory distress with a shortness of breath, respiratory rate of 32, audible rails in both lung fields, heart rate of 110 and a blood pressure of 138/90. She was sitting in a wheelchair, conscious but unable to communicate. The medical history was provided to us by the nursing home staff. She had suffered a stroke 2 years prior, COPD, and hypertension. When we asked about the patient's code status, we were told that there was no advance directive and that she was a full code. So we started an IV of D5W, gave her oxygen by non-rebreather mask, and put her on the cardiac monitor for transport to the hospital. Now during the transport, her respiratory status deteriorated, so we sedated her, intubated her, and provided her with positive pressure ventilation with 100% O2. Upon arrival at the hospital, her vital signs had improved, but, well, I hope she's okay because it didn't look good for her.
I was the nurse who took care of Anna when she arrived at the ED. I took a report from the paramedics and the nursing home transfer sheet. She had a history of CVA 2 years ago, COPD, and hypertension. Apparently, she had suffered some respiratory failure starting 45 minutes before she arrived, was intubated by the medics, and transported here. She looked so frail and old. Anna grimaced when we moved her onto the stretcher. She was still somewhat sedated, but she did respond to painful stimuli. We started another IV line, and the respiratory therapist checked for ET tube placement. There was no family with her. There was a granddaughter listed as the contact person on the nursing home transfer sheets. We needed her consent to proceed with any further treatments.
Just last week, we were planning to take her out for the day to visit a friend there. She lives in an assisted living place just a few miles away. I was going to take them both out to lunch at this restaurant my grandma used to go to when my grandpa was alive. We don't get her out as much anymore since her stroke. It's really difficult to get her around in the wheelchair with her oxygen bottle and tires so easily. We were so looking forward to this lunch out. I just want to get her well enough so we can still do it. It meant so much to her. My grandma and I are so close. I owe her so much, and I can't bear to think of life without her. She's a fighter. She's been in the hospital before with her bad leg, and she always comes through okay. She's the one in the nursing home who keeps everyone else upbeat. Trust me, I'm sure she can do this again. We need to just give her a chance. I told the doctors and the nurses in the ER to do everything for my grandma to save her life. I know she doesn't want to die. She loves to see the great-grandchildren.
I'm an intensivist in the ICU. I first saw Anna on my morning rounds after she'd been admitted. Her condition was precarious at best. It was possible that she could get better, but it was unlikely in my mind. Her clinical status was critical. Her blood pressure dropped overnight. She required neosynephrine to maintain an adequate blood pressure. She was sedated on Diprovan and was on broad-spectrum antibiotics. Her ventilator settings included high levels of oxygen and PEEP. Her chest X-ray revealed bilateral pneumonia, and I was concerned that she might be developing ARDS. We asked for an infectious disease consultant to see if she could possibly receive Xigris, which is a very expensive antisepsis agent. We also needed to make a decision about initiating tube feeding through a nasogastric tube. We had her on medications for her COPD, and we were also giving her steroids. The next day, I had the chance to meet with Anna's granddaughter. She listened to me tell her about her grandmother's condition, and she listened to me explain our dire prognosis despite our best efforts. I told her grandmother might never come home today, but that was too early to make that kind of a judgment. I also told her that we needed to make a decision about whether or not to begin tube feeding. And I mentioned that limiting aggressive treatment was another choice that she could make. Well, she became openly hostile, demanded that absolutely everything be done to keep her grandmother alive. She said her grandmother would have wanted to fight and that she was there to make sure she had that opportunity. She accused the hospital of wanting to pull the plug because she was old and from a nursing home. Well, we started the tube feeding and continued to pursue an aggressive medical plan. Just wish I could be sure that's what Anna would want.
This frail 86-year-old woman was admitted to our ICU unit from the emergency department with a history of CVA, COPD, and hypertension. She was intubated in the field by paramedics and diagnosed with sepsis and bilateral pneumonia. Her name is Anna. We ventilated her and mildly sedated her, and we restrained her to keep her from pulling out the various tubes in the central line that had to be inserted on that first night. She was very unstable that first night, requiring aggressive fluid resuscitation and medication to control her blood pressure. She experienced a lot of pain, and I attempted some pain management, but her heart rate and blood pressure were just way too unstable. She had to be cardioverted when her medication failed to slow her heart rate. We did everything that we could to save Anna's life, but I think she's dying. She had no advance directive, and her granddaughter, Christina, wanted us to continue to do everything we could. Christina has had to make some very, very tough decisions over these last 10 days. She was aware of her grandmother's prognosis, but any attempts we made to discuss Anna's wishes about her care were met with avoidance or outright hostility, and she refused to participate in a palliative care consultation. It's so distressing. Anna's been condemned to a life on the ventilator, with no meaningful interaction with her granddaughter or her environment. I mean, she can't even enjoy the simple pleasure of the taste of food. What are we doing? We failed her, and we failed Christine. Anna has come to require chronic care, and she was moved to a general nursing unit. Sometimes I don't like being a nurse.
After being transferred from the ICU, Anna is now a patient on my floor. She is ventilator dependent, is unresponsive, and uses a feeding tube for nutrition. She has C. diff infection and now shows some renal insufficiencies, which will soon require dialysis. With all of this, she's still a full code. We all know that Anna will never recover from her organ failures, but her granddaughter comes every day and continues to insist that we keep doing everything. Christina is very intimidating and threatening in her behavior toward us, but she spends many hours reading and talking to her grandmother. We feel sorry for Anna. Actually, for Christina too. But we also feel that this daily poking, prodding, suctioning, and needle sticks is cruel and inhumane for Anna. We feel that our professionalism is being compromised by having to provide what we consider to be inappropriate and futile care. We all agree that we would never allow this to happen to one of our family members. I'm the social worker on the floor where Anna is a patient. I first met Anna when she came to our unit from the ICU on a ventilator. She is unable to communicate and requires full care. It's my responsibility to plan for Anna's discharge and to support her family through this very difficult process. Because Anna can not be taken off of the ventilator, she can't go back to the nursing home where she was living before. She's totally dependent on the ventilator, and now with the possibility of needing dialysis, it's going to be extremely difficult to find a facility that will care for her. There are only a few facilities in the state of New Jersey that have beds for patients on ventilators who need dialysis. The cost of these beds is somewhere between $20,000 and $30,000 per month, and the cost is not covered by Medicare.
Christina will have no choice as to where Anna is placed, and she'll have to accept the first available bed, even if it's in a part of the state where it would be difficult for her to visit. When I first sat down with Christina, it was clear that her expectations were that Anna would be able to recover some quality of life eventually, and be able to either stay in a hospital or move to a facility that Christina chose. There's very little hope for any improvement in Anna's case. You know, none of us want to give up hope. We all want a miracle. I just don't think that's going to happen.
I always knew that I never wanted to linger in a hospital on all kinds of machines. I wanted to live my life to the fullest, but when it's over, you know it's over. I'm not afraid to die. I just want to be comfortable and not in pain. I want my dignity to be kept intact. I was quite sure that Christina knew how I felt. I would see to it that all this high-tech nonsense didn't keep me around too long. I know this is about what happened to me, but I am sure there are many others in my situation. I'm hoping that you can look for better ways to address end-of-life care in the hospital, and for that matter, in the nursing home where I was. It's difficult, and one never knows just what lies ahead. But I can tell you this. What happened to me surely was not what I wanted. Perhaps I should have done something differently. But nobody told me what that might be. How could you have helped my granddaughter to understand a better way to be? She is only trying to do what she thinks is the right thing. God. She must be having a terrible time with all you people pressuring her to make decisions. Think long and hard about my story. Please find a better ending for me.
The palliative care program at Atlantic Health created Anna's story to raise awareness.
The title of the lecture is "To Be or Not to Be" is not the question, because every life comes to a natural end, and we have to do a better job than what we're doing. I'm going to show you some numbers from the state of New Jersey compared to the rest of the country. I have nothing to disclose. Our goals today are to talk about all this. Obviously, I'm going to sweep through. So why do we do these things? Well, we do these things because we're taught how to do them. We're not so much spending a lot of time talking about when to use that how judiciously. We're trained in medical school that the patient has A and we're supposed to do B. It's a mathematical equation. They have a stroke, we give this intervention. They can't breathe, we put them on a vent. They have a GI bleed, we need to scope them. So we have a very linear thought process when presented with a patient with a specific medical problem. It makes us feel better because that's our comfort zone. That's what we were trained to do. So we need to talk about this because we're going to breeze through it. From World War II to the early 70s, we had this explosion of technology. So 100 years ago, we know people died at home. The family doctor came to the house. Yeah, she's dying. Everybody in the family was involved. And then World War II happened, and we developed some amazing technologies. Most of it came from the battlefield. And then through the 50s, we started developing ventilators, dialysis, all these great technologies, pacemakers. Then we thought, gee, we have all this technology, let's put it in one place in the hospital, and ICUs were born. And then in the early 60s, we developed CPR. Now we teach Boy Scouts and Girl Scouts to do CPR. It's pretty much we want everybody to know how to do CPR. And then if you're old enough to remember, I grew up in the 60s and 70s. 911 wasn't ubiquitous like it is now. You pick up your cell phone, you call 911, but back in the early 70s, you had to wait for it to come to your town. It was in the cities, then the suburbs. Now it's pretty ubiquitous. So if you remember your high school science, you're gonna have post-traumatic stress, right? So there's Newton's first law is the law of inertia. And the law of inertia says that if an object is gonna do something, if they're gonna keep moving, it's gonna keep moving, or if it's stopped, it's gonna stay stopped unless a force acts against it. So we need to stop and start talking about the inertia of the medical system. And where do we stop and how do we help patients and families navigate what is going to be inevitable for all of them? So like I said, we had this rise of what we call the treatment train. So patients get on this train and then all of a sudden we kind of lose a little perspective. We don't know who the conductor is. Is the patient in charge? Is the family in charge? Is the doctor in charge? Is the insurance company in charge? Is the health system in charge? But we know that the patient's on this train and heading in a direction and we're not sure who's in charge anymore. We're not sure where the train's going. What's the destination? When do we actually get to the destination? When's it time to reroute, get on a different train, and how do we stop and redirect as healthcare providers helping to guide patients and families? So this is the Dartmouth Atlas of Health. Now, I'm just gonna run through some numbers. So New Jersey numbers are in the pink and the US numbers are in the blue. And this is where we rank. At the last two columns is where we rank between 2006 and 2014. So hospital days per decedent during the last 6 months of life. We ranked 49 out of 51. And then in 2014, we ranked 50th. ICU days per decedent in the last 6 months of life, we rank 51 out of 51. Physician visits per decedent during the last 6 months of life, we are 51 out of 51. Percentage of deaths associated with admission to the intensive care unit, we're 51 out of 51. Enrolled in hospice at the end of life. So the US average is 27%, 52%, we're at 47%, and we rank 39th out of 51. Days spent in hospice, so the rest of the country is 23 days, we're at 19 days, and we rank 31st. And then again, Medicare spending and resources input during the last 2 years of life, we rank number 50 out of 51. New Jersey is last in the country in providing end-of-life care, and we have to figure out a better way to do this. What are we doing differently? This has been studied and studied and studied, and we have to start talking about it as the physicians, captains of the ship that we are, to help guide families into an easier ending. Now, this is last week, November 21st, the Governor's Council on End-of-Life Care published their report. It's been an 18-month study. I have a copy of the report, and Gwen will email it to anybody who wants it if you want to read through the whole thing. But I'm going to give you some summaries from this report. So there was a coalition formed, which is called the Goals of Care Coalition. From this Governor's Council, this council was formed. Now, what is going to happen in the next year or two is there's going to be robust training for providers, the creation and funding of fellowships. New Jersey right now has 2 palliative care fellowships. One is at Rowan at Cooper, and one is at Rowan at South Jefferson. The one position is not funded right now, so we're graduating 1 fellow a year, and I ran the fellowship for UMD&J, and the fellows were offered probably 15 jobs the day they signed the contract to start the fellowship. So we passed all that information on. So there's going to be funding more for training, facilitate the integration of palliative care and standardized screening tools for palliative medicine across the continuum of the healthcare system. Nursing homes, home care agencies, assisted living, healthcare systems, automatic screening tools that these patients are frail and at risk, and that these should trigger these advanced conversations. It already actually is in place to promote the implementation of an electronic registry of pulse forms. What is happening is, even when it's documented in the record, patients are showing up at a different facility, and it says DNR, DNI, and then the next page it's not filled out, and then the following page, well, she can intubate. So there's going to be an electronic registry that can be accessed from anywhere, and that patients' wishes and goals will be noted right at that point of entry. Another thing that came out of this study was they're allowing mobile intensive care paramedics to provide non-emergency home visits to patients with chronic illnesses, CHF, COPD, that should be COPD, sorry, cancer, Alzheimer's, Parkinson's, etc. So advanced illnesses that may be compromising the quality of life, who need palliative care and do not qualify for home care or hospice services. I want to add that the Grunin Foundation just provided, I wrote a grant earlier this year, so they provided $500,000 to our organization, who employs me, not Barnabas, but I'm employed by the VNA. So I have $500,000 to provide physician home palliative consults to hopefully eliminate unnecessary hospitalizations. So we hired a physician. She started August 1st, and she's conducting home palliative consults, which, if it's not covered under the patient's insurance, the grant is going to cover the shortfall. So there's a lot of family physicians already feeding patients into this program. And if they're not appropriate for hospice, not appropriate for home care, the palliative physician will visit the patient in the home once a month to see what medications are needed in terms of managing symptoms, interface with the rest of the system, the rest of the healthcare team. So that's something new for Ocean County. That grant was just provided by Jalen and Grunin to do that. So another thing that came out of the report is to increase community awareness, education, and outreach to ensure more residents are thinking about, discussing, and documenting wishes for families and healthcare providers. Also, in response to this report, and I just shared this with Gwen, we've created an end-of-life care palliative speakers bureau. That Gwen will also have that flyer. It lists about 40 different topics in end-of-life care, from very advanced symptom management, basic lectures, if you know organizations or senior citizens groups. They're geared to pretty much everybody from high-level ICU physicians down to lectures for the public to make them more aware. That is also available free of charge. If organizations go, sometimes physicians get paid X to give lectures, so of course that would be a donation to the Speakers Bureau. So let's look at just this hospital. So we pulled the records for all the codes in 2016, and I presented this before, but now we have some comparison data. So in 2016, there were 189 codes. That means more than one code per patient sometimes, so there wasn't 189 individual patients. So 127 of those patients survived the initial code. That was about 2/3. 22 of those 127 patients survived to discharge, which was less than 12%. 122 of the codes were in ICU. So that's, again, 2/3, and 1/3 were between the ages of 81 and 100. So we put that aside. Then we started this campaign of awareness in 2017 about code status, because a lot of these charts, when we looked at them, were not full code patients. They were code status not addressed. So the default in the system is that we code people if the code status isn't addressed. So these are people that maybe had it documented on their charts, or they had their wishes known, but nobody actually put the order in one way or the other. So they were blank when it said code status. So the next year, so we started this, let's talk about it. So the next year there were 256 codes. 191 survived the initial code. So we went from 2/3 to 3/4 survival. 47 patients survived to discharge. We went from less than 12% to over 18%. And 137 patients were in critical care. So we went from 2/3 down to just over a half. And still 1/3 of the patients were between 81 and 100. Now, did we get better at coding people? No. The skill set stayed the same. What we got better was selecting the patients, because if we code the patients that truly can benefit from that intervention, our survival to discharge and our outcomes will improve. If we're coding patients just because they're at the end of their life and have advanced illnesses with no chance of recovery, then our statistics are going to be way, way below national average. We have to talk about it when they come in the hospital. So what do we know about CPR? So like we said, it first developed in the 1960s. It was originally not recommended or advised in cases of advanced terminal illness where death is not unexpected. So 17% of hospital-coded patients nationally survive to discharge, but less than 2% if they have known advanced illnesses. So CPR is not recommended for those who have 1 or 2 chronic debilitating medical conditions, those who are dependent on others for their care, or have lived in a long-term care facility, those who have a known terminal illness, and it's only one of the only medical interventions that we need consent not to do. So I need consent if I'm going to put an IV in you, but this very, very aggressive, invasive intervention, I need consent not to do it. So when we're talking about this, we have to talk about what the goal is. So, and we're going to talk about some strategies, some things that came up when the granddaughter was talking, that very simple, known things that we can say and not say to help guide families. So we have to ask, what's your understanding of what's happening? Ask them the question. Don't walk in and tell them, because what ends up happening is that we go in and we'll say, oh, she needs less oxygen on the ventilator today. And you're like, okay, she went from 100 to 90%. Not really, any clinical significance. We know that. Or, renal comes in and says, oh, her creatinine's a little better today. And she went from 9.8 to, 9.4. So we're not giving good, usable information. So I always ask them, what have they told you about what's going on? So then I have a gauge of how much are they hearing versus how much are we saying. Because what we're saying is not what's being heard sometimes. I don't make any assumptions based on somebody's education level. I've had judges, dentists, I've had other physicians that I've talked to in consults, and you can't make any assumptions about what they understand. I ask about tell me about 3 months ago, tell me about 6 months ago. What's going on physically, functionally, medically, emotionally, and spiritually with this patient that's causing a decline? When you look at somebody who has an illness right now, is this a culminating event or is this a sentinel event? So if this individual is out playing golf and going to their bowling and playing bridge with their friends and something catastrophic happens, okay, that's sentinel. But if they're in 4, 5, 6 times with, again, sepsis, again, aspiration syndrome, again, another fracture, this could be a culminating event, not a sentinel event. And each incident needs to be evaluated in that way. Is this a sentinel event that is changing the course of this patient's functional and physical status? Or this is part of a long, continuous decline? So then I want to tell them what the medical information is and what it means in this particular patient and this particular situation. Obviously stay away from any kind of medical terminology. So what I think happens, and I use this a lot with families, I'll draw this picture. The families are at the side of the road and they know the house is burning down. And people keep driving by and they get out of the car and they say, I think the house is burning down. And they say, I'm here to fix the window. I heard the window's broken. And they put on the fire gear, they go in, they fix the broken window, they get it back in their car and they drive on. And the next person drives by and they're like, isn't my house burning down? They're like, I'm the carpet guy. I'm just here to fix the carpet. And they get back in the car and the family and the patient know what's happening, but no one's talking about it. So then I ask them, like after we go through this medical review, head to toe, labs, physical, functional, what's going on with the echo, the kidneys, everything. Do you have any questions about what I just went over? Now everybody's on the same page, like in the same boat rowing in the same direction. And based on the information, what is the goal? Excuse me. And are these interventions, what's the goal now and what's the goal if things get worse? Patients and families want recommendations. They don't want to say, well, it's up to you. They want solid information that can help them make good decisions. I always support the decision they make, but I'm not afraid to tell them what concerns me. So with the granddaughters, our grandma's on a vent, we want everything. All right, we're gonna trach her. I said, we can trach her, we can send her to a facility. This is what concerns me. I'm not sure that she's, the benefit and burden of what we're gonna be doing may be too great. So she might not be getting anything out of that, and it might be a greater burden to her. So we've talked about this before. Dying is a process. So we don't kind of eat our last meal and pass away. So, and it's difficult. We're good with the event. Like when somebody dies, we know they died. But where in the process is your patient? How do you really nail down what the prognosis is? So now a couple of things that came up in that film that you heard that we hear all the time. So the first one that we hear all the time is we want everything done. So the majority of us do what everybody did in the film. Like, we're like, okay, the family wants everything done, and we walk out of the room, and then we bitch to each other that the family doesn't get it. So when somebody says we want everything done, we want to explore that a little bit more. So what concerns you that everything hasn't been done? Every life has a beginning, every life has an end, that we get to choose how that end occurs, but not if the end is going to occur. In every illness, we do reach that point, and now you've cracked the door and maybe have an opportunity to explore it a little bit further. And then ask what concerns you about your family members passing. If you don't ask this question, people will tell you, like, I'm dependent on the Social Security check. Oh, well, I don't have the money to bury her. Oh, what do you think of, I've had some startling responses when we get down into, when we drill down a little bit to this question. Another one that we hear a lot from people is, yeah, I know exactly what you're saying. I know that, her prognosis is poor, but I know that we have faith and God's gonna heal her. So we have to stop seeing faith as a barrier to good care. So what they're actually saying when they say, we have faith, God's gonna heal her, is they're acknowledging what you just told them. They're acknowledging that they're in a place that medicine and man probably can't help, that they're gonna need a miracle. So you're not as far away as you think you are from this family. I see this as an opportunity, not an obstacle. So what I wanna point out is I'm happy that you're a family of faith, because people of faith don't understand that something greater than us is in charge of the bigger picture. Now again, you've stayed on the same side of the table as them rather than getting oppositional. You know, people say, well, you know, if faith was enough to keep people alive, we'd have 900-year-olds. That doesn't help. Excuse me. Another one that's kind of a showstopper in the ICU and other places is that we have hope. So hope is a powerful asset. It's not something that you want to take away. But you need to help patients and families redefine what they're hoping for. So we see hope as a two-sided coin. We have hope she lives, we don't have hope she dies. So now's the time to get a bigger definition of hope rather than that two-sided coin. What are you hoping for? Or you hope that she accomplished everything she needed to. You hope that she was loved, that she's not in pain, that she's not suffering. And then you heard all these phrases in that film. I know what you're saying, but my grandmother's a fighter. She's come back from all of it before. This is another stop for healthcare providers. Like, what do you say when somebody says this? So being a fighter is a mental, an emotional, and a spiritual state for an individual. She's a fighter. She's going to keep fighting. So when illness becomes advanced and chronic and debilitating, despite the fighting spirit emotionally and everywhere else, the body's going to continue to fail. And that's what we have to communicate. And at that point, that her emotional and spiritual state cannot overcome the body failing, what's the goal? So now you want to translate those goals into a specific plan. So if time was short, knowing time was short, what is important? Did she want to be home? Did she want to be with the family? Do you want to focus on comfort? Is there an upcoming life event that you would want to be a part of? A wedding, a graduation, an anniversary. And then mutually decide with the patient and the family steps necessary to get to that particular goal. I had a gentleman once about 10 years ago, and he wanted to make his great-grandson's bar mitzvah, and that was the goal. So, and he had no ejection fraction, no kidney function, and we had him on milrinone. We had everything to improve the chance that his heart would keep beating appropriately until he could get to the bar mitzvah. And that last week before, so this was like a 4-month plan, tenuously, and he died the night before the bar mitzvah. And the family was so okay and everybody was on board. It wasn't sad that he missed the bar mitzvah. It was that they were all working towards a specific goal and they were ready at the end to say, we tried and he died peacefully and he's going to be at the bar mitzvah anyway. So there are some extraordinary steps to take if there's an extraordinary goal to achieve. But to take those steps for the sake of taking those steps with no intended goal at the end is not fair to the patient or the family. The other thing is, and this was the hardest thing for the fellows to get a skill set, is how to be silent. How to be silent when you give this information, because we give this information and we're so compelled to like, oh my God, nobody's talking. What do I say next? What do I say next? And we know we interrupt patients. Like there's been studies about doctors interrupt patients every 18 seconds or something. But I always tell the fellows, he who speaks first loses. Don't be afraid of the silence. Just let it lay. And then some great things can come out if you let the patient and family talk first. So what's the goal? So there's common issues that come up. How do they feel about coming back and forth to the hospital? If they're in the hospital, how do they feel about being upgraded to the intensive care unit? Tests. What is their code status? Not if your dad dies or you died, do you want us to bring you back? Remember the title of the lecture? To be or not to be is not the question. The question in advanced illness is, when your heart stops and you pass away, is the goal to make sure that you pass away naturally, peacefully, or do you want to be hooked up to machines? How do they feel about artificial nutrition, hydration? It's important to know what the facts are before you recommend feeding tubes. And then antibiotics. I see people a lot of times getting repeat courses of antibiotics for stage 4 ulcers, for chronic aspiration. But we haven't removed why they're getting infected, so the antibiotics eventually are going to cause a greater burden than a benefit. You're going to get C. diff. Do you do a diverting colostomy? All kinds of, you're kind of down a rabbit hole. How do they feel about blood products, being at home? How do they feel about hospice? And then when trying to decide about, different treatment options, if it's not going to achieve a certain goal, then maybe you shouldn't go down that path. So, you don't have to be good at this. You have to know what your skill set is. And like I said, everybody, all of us, at some point in our careers, learn to deliver a baby. And if you learn to deliver a baby this way, on this side of the screen, then you could probably deliver a baby. But if your idea of delivering a baby is that side of the screen, you probably shouldn't be delivering babies. So you don't have to be good at this, but you have to know who amongst your colleagues is good at this conversation. Who can help you with this? Is it the nurse who's been with the patient for 12 hours a day? Is it the social work staff? Is it another physician on the care team? Is it palliative care? Is it the hospice team? Is it the transitions of care team who see patients for repeated hospitalizations? But doing something for the patient doesn't mean you have to do something to the patient. Now, anybody have any questions? I think we finished.